Hello, Emily.
Hey, Rebecca.
Looks like Dr. Payne is on as well. And I see we have a few participants joining, so thank you. We'll get started here in just a minute. Hello, Dr. Payne. I think you might need to unmute yourself.
Oh, they muted me again. Hi.
Yeah.
I was like, oh yeah, they keep changing this WebEx app, so I'm still trying to get used. That's why I logged in early, so I can get the wrinkles ironed out.
Yeah, WebEx is fun sometimes.
Yes.
All right, you both should be panelists, and Robbie, you should have presenting ability at this point.
You can see my slides.
Yep, looks great.
How's my audio?
Yeah, it's good. I can hear you.
Good. Okay. I thought about using my AirPods, but because like I'm on MLK here, and it's been crazy. Like a lot of helicopters, fire trucks, that kind of stuff. So
Yeah.
I'm just gonna roll with it with no AirPods because I don't want to mess this up.
Sounds good.
Okay.
Thank you for those of you that are joining us. We'll be getting started in just about 5 minutes, but if you want to go ahead and introduce yourselves in the chat, this way we can see who's here. Just select everyone and then type your message in the chat. Thank you. Thank you everyone for joining us today. We're going to be getting started here in just a minute. I just wanted to welcome those of you that are joining, and if you could introduce yourselves in the chat. I'm already seeing a lot of familiar names from our previous BHIPP mental health crisis training, so thank you for taking the time to join us again today. All right, well, my clock is showing 12:30, so we'll go ahead and jump in. Welcome, everyone. Thank you for joining. My name is Rebecca Farrow. I'm a part of the BHIPP team. I'll be introducing our presenter today and facilitating our Q&A at the end of the session. And just a few housekeeping items. If you are attending today for CEU credit, you will need to attend for at least 45 minutes. If you would like to receive either CME or CEU credit, you'll need to complete the evaluation survey. This will be provided via the chat at the end of the session and also over email after the session. CME and CEU certificates will be sent within 3 business days of survey completion. Following today's presentation, there will be time for questions, so please enter these into the chat. The recording for today's training, slides, and related resources will be available on our website next week, and we're going to put a link to this in the chat as well. This is part 2 of the suicide prevention webinar series, and if you missed part 1, we do have all of these materials available on our website. Again, that link will be available in the chat. For those of you that are unfamiliar with BHIPP, I would like to provide some information about our program. Maryland Behavioral Health Integration in Pediatric Primary Care, or BHIPP, is a child psychiatry access program that supports the ability of pediatric primary care and emergency medicine professionals to address and manage mental health concerns. BHIPP is a free statewide program that offers telephone consultation, resource and referral networking, care coordination, telepsychiatry, telecounseling, and training and education opportunities. The BHIPP Warm Line is staffed by a team of child mental health specialists and is available Monday through Friday, 9 a.m. to 5 p.m. And our phone number and website will be placed in the chat for you. It is my pleasure to introduce today's BHIPP Mental Health Crisis Training, Suicide Prevention Part 2, Safety and Crisis Planning, presented by Dr. Robert Payne. Dr. Robert Payne was born and raised in Baltimore, Maryland. He received his BS in Chemistry and Psychology cum laude with honors in general education from Frostburg State University in 2005. Following graduation, he worked as a mental health worker on the children's inpatient unit at Sheppard Pratt and Enoch Pratt Hospital. He then completed his medical education at the West Virginia School of Osteopathic Medicine in 2011, his adult psychiatry residency at the Charleston Area Medical Center, West Virginia University Charleston Division in 2014, and his child psychiatry fellowship at University of Maryland Sheppard Pratt in 2016. Upon completion of his training, Dr. Payne stayed at the University of Maryland, Baltimore as an assistant professor in the Department of Psychiatry. He is the child psychiatrist for the UMMC Child Psychiatry Consult Liaison Service, provides telepsychiatry services for the Maryland Department of Juvenile Services, and supervises trainees in the ADHD and mood disorders clinics. His areas of interest include developmental trauma, attachment disorders, complex psychopharmacology, psychodynamic psychotherapy, positive psychiatry, and mentalization-based psychotherapy. We're very grateful to have you here today, Dr. Payne. Thank you for sharing your expertise with us during this session. I'll go ahead and hand it over to you.
Thank you so much, Rebecca. It's an honor to be here again today to discuss this very important topic. So today we're gonna talk about safety and crisis planning with suicidal youth and adolescents. I have no potential conflicts of interest to disclose. I am a faculty member at the University of Maryland School of Medicine and the Department of Child Psychiatry. I receive salary funding from the state of Maryland via the BHIPP grant, and I'm a member of ACAP. So the learning objectives for today's talk: learn evidence-based treatments for non-suicidal self-injury in children and adolescents, describe the specific components of an evidence-based safety plan intervention, and lastly, to discuss additional elements to consider specifically for kids when engaging in safety planning. I would like to acknowledge our colleague, Dr. Hal Kronsberg, who created the majority of the slide content presented today. So big thank you to him. First, we'll start with a case. So in the privacy of his bathroom, Alejandro, 15, prepared to cut his wrist. He knew it would hurt and knew people would wonder why, but he didn't care. It hurt the first few minutes of cutting, but soon he felt no pain. He felt only relief. Then he looked down at his wrist. The amount of blood in the bathroom sink shocked him. He wrapped his wrist in a towel and told his mother. She took him immediately to the hospital, where the doctor stitched up his wound. The ER social worker was concerned. She asked Alejandro, "When you cut your wrist, how much did you want to die?" He responded, "I didn't want to die, I just wanted to feel better." He explained that his girlfriend had broken up with him that day at school. "I couldn't stop crying. When I cut myself, it calms me down. I swear I wasn't trying to kill myself." The social worker believed him, but only after completing a suicide risk assessment and talking with Alejandro's mother for corroboration. Alejandro had not previously revealed any signs of suicidal thoughts or behaviors. There was no sign that he had undertaken preparations to end his life. For safety planning, the social worker helped Alejandro come up with safer things he could do to relieve emotional pain, as well as people and places he could turn to for distraction and help. He was referred to an outpatient psychotherapist and was discharged home with his mother. So for non-suicidal self-injury, treatments at work. So therapy is the gold standard of treatment. The strongest effect sizes are for dialectical behavioral therapy, or DBT, cognitive behavioral therapy, or CBT, and mentalization-based therapy, MBT. Key ingredients in all evidence-based treatments include focus on family interactions, frequent meetings with the adolescent or child, and emphasis on self-care, including sobriety, sleep, and increasing in positive experiences. So just to compare the two more commonly cited options. So DBT has the strongest evidence base for non-suicidal self-injury. There's mix of group and individual treatment. There's a parent component, emphasis on skills to replace self-injury. Because it's thought of as a behavior with clear antecedents and consequences that perpetuate and reinforce the behavior, replacing that behavior with another behavior or a skill that creates, the same desired outcome is really the goal. There's also on-call skills coaching, which is really helpful in the moment of crisis, and it can be incorporated in part of a safety plan for those that have this available to them. But again, one downside, it's very hard to find DBT programs, particularly in rural areas. CBT has somewhat of a weaker evidence base. It's an individual and parent treatment component. There's an emphasis on thoughts and behaviors and how those pertain to feelings. There is no skills coaching. It's much more commonly found, and it treats many comorbidities. So a DBT skill example that can be used in non-suicidal self-injury. So what we can coach our patients or clients to do is when they feel the urge to self-harm, instead grab an ice cube or running their hands under ice cold water, or putting their hands in like a cold ice bath or something like that. So that helps to change your body's temperature and it kind of gives them that sensory experience that can approximate what an SSI does for them. Intense exercise, walking quickly or briskly, climbing the stairs, jumping up and down, running, or if they have like an exercise bike or a treadmill available to them, doing that, that surge of adrenaline can also create, again, like approximation to what the NSSI does for them in periods of emotional arousal. Paced breathing and paired muscle relaxation. So this is so in the DBT skills manual, they have a lot of different mnemonics. One of them would be TIPP, T-I-P-P. So a very good book that's available wherever you get your books is Helping Teens Who Cut, Using DBT Skills to End Self-Injury. And this is a book intended for lay audiences by a major DBT authority, explains the concepts and skills, and it may help parents respond to emotional distress more effectively with more validating responses. Here are some more web-based psychoed resources. So self-injury outreach and support, self-abuse finally ends, and the Cornell Research Program on Self-Injurious Behavior in Adolescents and Young Adults. So these are sponsored by credible academic institutions and are filled with very useful, up-to-date, and peer-reviewed information. So we're going to shift gears to suicidality. Your patient is suicidal. Now what? So the big question is, does the patient feel they can keep from seriously harming themselves with appropriate supervision? And appropriate meaning the typical amount of supervision that is developmentally appropriate for a kid of that age. And do the parents and caregivers feel that they can provide adequate supervision to keep their child safe? If yes, you can proceed to safety planning. And then after safety planning, reconsider the above question to ensure that all parties feel the safety plan can be realistically followed. If no, further evaluation is needed immediately. Consider ED or alternate setting referral. Safety planning. So there's few robust studies in safety planning alone in pediatric populations. However, in an adult population, safety planning plus a single phone check-in reduced 6 months suicidal behaviors by 45%, with ED visits for suicide-related concerns. The intervention took 15 to 45 minutes to conduct. Again, not a very long amount of time, but it can be very impactful. Safety plans are often combined into a comprehensive treatment approach, such as in CBT or DBT. So a word about the safety contract, previously known as a no suicide contract. In this situation, the patient promises either orally or in writing not to act on their suicidal thoughts within a specified period of time. After decades of widespread use of no suicide contracts, most experts now discourage practitioners from using them because, if you think about it, far fewer suicidal people would seek professional help if they could resist their impulses so easily. They would be able to call in their strengths, resources, self-control, and social supports to resist suicidal urges. Our role is to help people build those assets, not presume they already exist. So this is the point of a safety plan, creating a concrete way to collaborate with the suicidal person about ways to resist and acting on suicidal urges. So some principles for safety planning include providing kids and families with a prioritized and specific set of coping strategies and contexts should suicidal thoughts emerge, assuming that they will. Seeing suicidal crises and intense but temporary challenges. They are crafted in close collaboration with the individual who use it. A good safety plan is concrete, detailed, and within the patient's ability to achieve. So this is a commonly used patient safety plan template. It's available on the web at this link. When you Google safety plans, it's usually going to this is usually the first thing that comes up. There is a step by step. As you move from step 1 to step 5, there's a very gradual process, moving from internal coping to external coping to reaching out for help. Additional considerations for kids would include a plan for increased supervision and establishing a check-in system. Okay, step 1. If this is, the first time that they've had these thoughts or engaged in some sort of self-injury, then you kind of have to start from scratch. But if they've engaged in this stuff before, you could collaborate with them and ask them to reflect on early warning signs from previous crises. So at this point, we're emphasizing thoughts, feelings, and behaviors that the adolescent can identify on their own. And this could include observable behaviors as well that parents, caregivers, or other informed adults might be able to recognize without the adolescent saying that they are present. For example, if someone's about to have another depressive episode, oftentimes they'll start withdrawing to their room or stop going to school. Their grades might slip. These are more objective signs that something might be on its way. So that could be part of the history. We move along to step 2, internal coping strategies. The initial step meant to enhance self-efficacy. So in step 1, they identify signs that a crisis may be developing with thoughts, feelings, and other things that might be observable. These are the first steps that they can do to help themselves feel better. The clinician and patient can work collaboratively to find different ways of coping with intense emotions and impulsivity. Some examples you can find on this link: delaying action for 15 minutes, just simply saying, I'm going to table this and try to let the wave of emotion pass. And one metaphor that I often use is, instead of thinking of emotional crises as fires that need to be extinguished, it's more helpful to think of them as waves that come and go and have a natural ebb and flow to them. And I think teenagers particularly find that metaphor helpful. And when they see them come and go and they find that for themselves, I think they're more able to like ride the wave, so to speak. So other things that might be helpful are petting a cat or walking a dog if they're animal lovers, listening to music, watching a funny video on YouTube, exercise. These strategies, if they're part of the safety plan, should be usable at any time by the individual. Moving on to step 3, using social contacts as a means of distraction from suicidal thoughts. So after coming up with ways to distract oneself alone, the plan moves on to the people and places a person can turn to for distraction without disclosing their need for help to others. These are not meant to be emotional supports per se, but rather people around whom they feel safe or they feel like they can kind of take their mind off of things without necessarily verbalizing what they're going through right at that moment. The place may be private or public. Again, the aim is to focus on self-efficacy. As I was studying for this talk, I learned and was reminded that this template doesn't necessarily have to be complete. Every single blank doesn't necessarily have to be filled out. The emphasis is on identifying something that's most helpful and more realistic for the patient to follow. Is this a template? So step 4, contacting family members or friends who may be able to help with the crisis. These might be different people they can go to just to get their mind off of things, as in step 3. Step 4 are people that have agreed that they can be contacted if the person is continuing to struggle with these suicidal thoughts. They should know that they may be contacted, and they should be adults, ideally. So at this stage, the actual crisis is meant to be discussed openly. Sometimes validation and support is sufficient to alleviate suicidality. In the literature, it talks about bearing witness to the patient's emotional pain, because people that either commit non-suicidal self-injury or have thoughts of suicide are unquestionably and invariably experiencing profound emotional pain that they just want to end or to just go away, and they're suffering deeply. So to kind of bear witness to that and hear that is often very helpful and often can diffuse the crisis in and of itself. Distress and other psychiatric symptoms may remain, however, and so there is another step. So mental health professionals or agencies, at this stage, we're moving sequentially down the list, and these previous steps have not diffused the crisis at this point. But by practicing skills in distracting, coping, and socializing before asking others for help, the person can build a sense of self-efficacy about their ability to resist urges to self-harm or suicidal thoughts. This should be discussed in advance with outpatient providers to ensure that conditions for being emergently contacted are clear. In our hospital, in our inpatient unit, we often will put the Baltimore City Crisis Response Team, BCARS, on this as the local urgent care service, but depending on where your jurisdiction of practice is, this could be another local urgent care or crisis mobile team. If they're already, in therapy or already receiving psychiatric care, then these could be the clinicians that are included. But again, that clinician should be aware that they're part of the safety plan, and there should be a after hours number. So making the environment safe. Some aspects of this should be step 0, firearm safety. But the safety plan is created like this intentionally. So completing the other steps of the safety plan first can help the person build motivation and recognize that other options exist besides suicide. So that was kind of the thinking based on what I read. But a word about firearms. So firearms used in pediatric suicides come from the youth's home in approximately 9 out of 10 deaths. Dissociation of firearm ownership and suicide was 2 times stronger in adolescents than adults, and child access prevention laws may reduce adolescent firearm suicide by 13%. While the AEP recommends all firearms should be securely stored in a locked location, unloaded and separate from ammunition, only 3 in households with children and firearms actually do this. We would like to see that number be higher. Other aspects should be done on an as-needed basis, including locking medications away and preferred objects for self-injury. There are these combination locked boxes that can contain medications and other sharps. They're available either Amazon, Walgreens, other pharmacies have them. They're not very expensive, but they can be very helpful. I used them when I was the child psychiatrist in the mobile treatment team, and they were quite helpful for families. So additional consideration for kids would include a plan for increased level of supervision at home. This could be anything from limiting time left alone, increased time spent with family, and monitoring social media. And parents should make this explicit. So when you're intervening in a crisis and you're forming a safety plan with a family, this could be where things get a little hairy. But in my experience, taking your time and making sure that this is agreed upon and all parties are aware of what the increased level of supervision is, whether they need to have their phone taken away and those kinds of things, making sure that everything is kind of planned in advance so that when the family goes home and they attempt to implement this plan, that there isn't another crisis that immediately erupts right after that. So being very proactive and talking that through with the family is very helpful. As well as devising a check-in system. There should be limits on both ends. So, supportive concern can eventually become nagging or helicoptering or whatever adjective you'd prefer. There's a delicate balance of parenting that I've learned as a parent myself, but the goal is to assess safety and not necessarily to manage parent anxiety. So again, with suicidal youth and adolescents, there's a lot of parental support required. So it's fine to adopt means of checking in beyond explicit verbal statements as long as it's predetermined. I've heard all kinds of really cool things that parents and kids have come up with, like different emojis that signal something so that they can communicate what's going on without having to actually say it, like a code system of symbols. Speaking of, with kids and their phones, they always have their phones, so if it seems unlikely that they're going to have a hard copy of their safety plan on their person at all times, there's an app for that. So the first one is Not Okay. It's a free app that contains a large red button that, when tapped, alerts close trusted contacts that the user is in urgent need of help. So this could be, part of step 4 of the plan. Once they've gotten through the first 3 steps of the plan, they are trying to let someone know that they're not okay. I think a really cool part of this app is it actually will send a GPS location so that they know where they are. It's almost like sending someone a pin. And then another app is simply like an app version of the safety plan we just went through with the template, and it looks like this. It's a free app, again, that allows users to program safety plans and their information. And if they need to contact someone, it's integrated with their contacts, so they can just go ahead and call them instead of having to actually dial the number. So going back to when we said, can they go home with a safety plan, or do you need to refer? Possible alternatives to an ED referral are very helpful. Walk-in behavioral health services. These are non-ED settings to evaluate mental health crises. They're not necessarily open 24/7, so it'd be helpful, or a good idea to check in what the hours are before referring someone. But in Frederick, there's the Mental Health Association. Hartford County has the Hartford Crisis Center. Montgomery County has the Montgomery County Crisis Center, and there's the Quick Crisis Walk-in Clinic at Shepherd Pratt, as well as in the Towson campus and the Elkridge campus. An very interesting emerging crisis-based treatment. It was a family-based crisis intervention with a 60 to 90-minute single session for suicidal adolescents and their families. This was studied and implemented in pediatric emergency rooms. And the components were elucidating the crisis narrative. So kind of like, what's been going on, how did this, what kind of step-by-step, a chain analysis of what led to what, so that people can kind of put together the story and identify what the triggers are and some other stressors that might be involved. Providing some psychoeducation, brief CBT intervention, and safety planning, of course. In this ED study, it reduced the need for hospitalization of suicidal adolescents by about half. From 68 to 38%, which is, significant. Not yet adapted to primary care settings, but this is in progress. I looked up this paper and I can add it to the chat, I think, which you will be able to get it that way when we're about to do our Q&A. So these are some recommended readings. This book in particular, Helping the Suicidal Person. I don't know if that's backwards for you or not. Stacy Friedenthal. It's a very good book. It's very practical and concise. I use it a lot. It's really, really good. So that's this reference right here. But these are all excellent resources. This is a new crisis hotline number, 988. It will be coming July 16th. So this patients, families experiencing mental health crises can call or text 988 and will be directed to the National Suicide Prevention Lifeline. I think this is a really cool new effort. Thank you all for your attention. That went a lot quicker than I expected, but giving us 30 minutes to discuss questions and have a discussion. I'm going to go ahead and end the show.
Wonderful. Thank you, Dr. Payne. And as Dr. Payne mentioned, we have plenty of time for Q&A now. So if you want to put those either in the chat or in the Q&A portion, whichever is easier for you, we'll look at both of those. When there's a question about the slides, those will definitely be shared afterwards. If you're attending today for CME or CEU credit, well, really, regardless, I'll make sure those will go out by email and they'll be on our website as well by next week. So I do have a couple questions. How do you respond to situations when the parent or caregiver is uncomfortable with the safety plan? They're not really feeling like sure that the patient will be safe.
Yeah, really good question. We see that a lot. So one thing that I've learned is, so if we're in a, so if like depends on, first of all, it depends on the location. So if they're in the ER, we can simply just observe them, and make sure that it doesn't necessarily have to be formed in one encounter. It can be a series of encounters where there's more and more exploration and discussion and collaboration, but the whole idea is to have an open channel of communication between the youth and the mom and a family and the clinicians, that everyone is on board that this is something that could be realistically followed and will be helpful. And it ultimately, comes down to the parent to keep that kid safe. So if they don't feel comfortable, then, you have to proceed with, and that's kind of what I said in the one slide, if going back to that particular slide. Do the parents, caregivers feel that they can provide adequate supervision to keep their child safe? I guess you can add, do they think this is a plan that will realistically diffuse crises, and or do they feel like they can prevent those crises from resulting in a serious attempt on their life or serious event of self-injury? But I think it's important to remember that suicide is a rare outcome of a suicidal crisis. Usually it is thought to be a temporary but intense, 24 to 48 hours that we have to ride through.
Great, that's very helpful. And we've got quite a few questions coming in the chat, so I'll start with the first one here. This is from a provider. So I am in a very rural area and everyone states that there's no help for a person that has already, I believe, attempted suicide. Is this an issue you have heard also? I assume there is help there, but people need to utilize it.
Yeah, that's a big challenge. So I did my residency in West Virginia, where I treated a lot of patients in very rural settings. And yeah, it's unfortunately, like, the more rural it gets, the more falls on the shoulders of individual, clinicians and providers that work with those underserved communities. And in terms of therapists, like, one thing that I'm not sure of, like, how it compares to like the evidence base that we have, but using like online platforms, I think I actually see a question about the things like BetterHelp or Talkspace. I have a couple of friends that use it and they found it to be helpful, but I'm not sure how it, like, specific to this issue what the evidence is, but I think it is a resource that we otherwise wouldn't have. And in my opinion, it seems like the COVID pandemic has made us a lot more creative and a lot more intentional about how we provide therapy remotely. So it seems like the evidence base is getting stronger. So if a patient is in a very underserved community, maybe that would be an option for them.
That's great. And I know you mentioned the BetterHelp and Talkspace question. So there's an addendum to that. Um, and that question I'll just read for everyone. Given the shortage of mental health providers for talking therapy, have you had any experience with the online therapists like BetterHelp or Talkspace? Do you have any feedback from teens or parents about those resources?
I do not about those specifically, but my the people I know that use those were actually and I think at this point some people have different preferences, like really prefer the in-person approach, or the virtual format is more convenient and more conducive to them coming regularly and working on their goals and attending. So there are people that still want like face-to-face therapy, but the patients I work with we provide our telehealth service through like our clinic. So my experience has not been with them with these talk therapy platforms, but I have heard good things from others, not from patients, though.
Another question here, when a patient has a positive screen for depression and/or suicide, how do you start the discussion with the parent? Often the parent is unaware, so having a few open lines would be helpful.
Yeah, that's a really good one. So if you interview the child or adolescent by themselves first, and then like first ask their permission for the sake of building a therapeutic alliance. Like, is it okay if I talk to your, mom? And if they say no, I'm like, well, I'm gonna do it anyway. um, and just kind of talk to them about like, I had a chance to spend some time with them, and there's some things that they've been struggling with that they might have been hiding from you, but have you noticed, like, kind of first eliciting what they've observed first, and like what do you think is going on, and kind of having them getting them to give their perspective, and then say like, okay, this is what um, this is what they shared with me, and this is kind of like a gray area in mental health, because normally we have like parent or patient doctor confidentiality. Some things, if they say, I don't want you to tell my mom, you really shouldn't. But one of them, I mean, one thing you should tell your parents, despite what your patients think, is suicide and having thoughts of hurting themselves. So that's something that you would have to share that regardless of whether it should be confidential or not otherwise. Having said that, having just it's kind of like opening the discussion, and in my experience, families are often just like, wow, I had no idea that that was happening, and more often than not, they take it very seriously. Usually especially if it's like a higher functioning kid, usually they have no idea that the kid's been struggling internally, but that can happen. And they're usually relieved to hear that they've shared that. And, um, I think it's a sign that the patient is very treatable and they have a better prognosis, the fact that they're willing to talk about that with a clinician.
And there's a follow-up comment to that question as well, that a few providers have seen parents that don't want to accept it, that their child may be having suicidal ideation. So not sure if you have any comments to add to that, but that definitely happens.
Yeah. So in one of the books I referenced here at the end, it's which one was it? Evidence-based treatment approaches for suicidal adolescents. They have a whole section in there about um, educating the parents to take this seriously. And if they refuse to take it seriously, you're kind of in a position where you then have to talk about like medical neglect, calling child protective services, unfortunately, if it gets to that point. But acting in the patient's best interest, if you're really concerned that they're going to harm themselves and the parents refuse to take it seriously, or just locked in denial, like I said last time, I'm a parent as myself, and sometimes I use that. I try to play that card to the best I can, and say like, if my daughter or son were experiencing these things, I would not want to believe it, but finding like using whatever club in my bag I could pull out, and if I fail to make any impressions that were getting them to shave down that denial, then you really have no choice but to involve a CPS kind of situation. So, but thankfully, it's, in my experience, it doesn't happen that often, but it has happened.
Yeah, hard decision, but necessary.
Yeah.
So our next question here, and thank you, by the way, for all these questions. They're wonderful. Please keep them coming. How do you determine how trustworthy a parent or teen is to taking the kiddo to the ER for eval? What criterion do you use for determining when to call an ambulance due to concern for noncompliance?
Yeah, that's a good one. So I don't know. It's sort of like I guess it's like a gut instinct, you know. If you have doubts that they would make it, in my experience working here, usually transportation is a major barrier. So using an ambulance is a good way to make sure that they're not only transported to an evaluation, but that they're if they actually have like if they go into crisis or become aggressive or try to run, that there's like professionals there that can intervene. So erring on the side of caution. And I think this also opens the door to like whether or not an emergency petition is indicated, using the police resource to make sure that they go if you're not sure if they're going to take them. But it's something that on a case by case basis, you kind of, and also, your families, who comes to appointments and who tends to not be super reliable. So I think you have to use that data and that kind of learning history to guide your decision making.
That's very helpful. Another question here, how would we get more information to a community to watch for signs? We have 2 huge bridges people like to go to and jump, and everyone states there is no help in this area and subsequently blames the bridge. What can we do if we do see a vehicle stop abruptly on the bridge? Is there anything that we can do to maybe deter someone at that point?
It's very thought provoking. I'm wondering where this bridge is. Yeah, wow, that's a big issue. I think they've like invested resources in, like, for example, the Golden Gate Bridge. They developed like suicide barriers and stuff like that. I suppose you could call the police if you see somebody, if you're out there driving and a good Samaritan and you wants to intervene, to call the police. Or I wouldn't encourage you to stop yourself, because I've watched too many scary shows where stopping on the side of the road to assist a stranger. My wife would certainly not allow me to stop the car. She's way too hypervigilant for that. But that's a really good question. I'm not really sure I know how to answer it, because that's like such a big problem. But again, the supervision, especially when it comes to kids, if you're concerned that they're going to use this as a method of suicide, trying to, until the crisis passes or until the risk seems lower, really having, like some kids you really just can't let out of your sight. That's the bottom line, because this is a very highly lethal method of suicide, is a jumping from a bridge.
So that's when that assessment comes in of finding out what the plan might be and being aware of that, hopefully before it gets to this point.
Right.
We do still have some more time. We'll go ahead and put the evaluation link in the chat. But if you do have more questions, we have some more time. I did have another question. Is there anything you typically do to make patients feel comfortable when actually completing the safety plan? If you have anyone that's maybe reluctant to fill out the form, are there any strategies that you use for that process?
Yeah, totally. So first, like I kind of said earlier, was that, so these patients are, coping with profound emotional suffering, and simply bearing witness to it, validating it, saying that, I know you're in pain, I know you really want to give up, and those kinds of things, acknowledging that suicide is an option, that kind of gives them a sense of, it makes them feel understood. And having your patient feeling heard and understood often is like one of the most powerfully therapeutic tools we have. And so that can, and so, so most patients I work with do not want to be hospitalized. Rather than using hospitalization to leverage them into completing the safety plan, we try to say, like, look, we don't want you, we want to do what we can to keep you safe at home. Like, that's the goal. Like, we want you to be where you're going to feel like you're around your family, you have your support system present. Because hospitalization is not a benign intervention, um, but it is an intervention that we sometimes have to reach for if the patient is just too emotionally dysregulated or simply unwilling to complete the safety plan and work with us. And we have really no choice, but it is a last ditch effort. It's a measure of last resort. Um, but in my experience, if you simply just take your time and try to use those therapeutic skills to validate the person's emotional pain and suffering and have them feel heard and understood, that usually helps them. And then kind of saying like, look, these are things you can do, and increasing that self-efficacy when you're completing the safety plan to help them see that there is, multiple strategies that they can use to help themselves feel better. And that's often very helpful. And they feel, usually committed to that.
Great, thank you. We have a few more questions coming in. What do you tell a person who's constantly saying how horrible of a person he is and he wants to leave this world? I've advised he go to the emergency room and he said he was put out. What do I tell this person?
Yeah, that sounds like someone that needs therapy. But again, like, I would probably start with a, psychoeducation discussion about how depression affects our ideas of self-worth and our attitudes towards the world, and how, using the metaphor of like sunglasses, like, when you have depression, everything you see and you perceive seems darker than it really is. And by helping them understand this is a treatable illness, that these cognitions that are pretty deeply rooted and require therapy usually to dislodge. But that psychoeducation discussion should be first, and that's usually what I say. This is a symptom rather than core to who you are. Also, some supportive interventions like, actually you're a very kind and caring, gentle individual, very smart, good at all these things, like giving them a lot of positive reinforcement. Um, that can also be helpful.
Okay, great. How do you work with a parent who minimizes the child's distress? For example, when parents, parents have said to the kiddo, you don't want to hurt yourself, or even he's just playing.
Yeah. Yeah, that goes back to like, that whole the book I just referenced, the telling parents like, to take it seriously. And what I say is like, this is not like they're not joking or they're not playing. Like this is very serious. Being very stern and very serious that kids do kill themselves, even if they were using this as a way to manipulate you or control you in some way, that would still require psychiatric care. But we have no other choice but to take all of these suicidal communications seriously. And it's very hard to hear, and it's very hard to believe that your kid would want to do something like that to yourself. So you kind of normalize that, but remain very steadfast that this is something that should be taken seriously and something that we take seriously.
Thank you. And just to call attention, Dr. Edwards put in the chat a resource from the American Foundation for Suicide Prevention about bridges. So for that question earlier about a local bridge, that's an issue.
Thank you, Dr. Edwards. It's awesome. Thank you so much.
And then another question here. What would you suggest for clients who have a plan or intent but have no lethal means?
Plan and intent, but no lethal means. Yeah. Well, that person still is thought to be an imminent risk. So they would probably require at least observation, if not inpatient care, because lethal means, might be something that they eventually find, but if they have a plan and intent, then that's as serious as it gets. Unfortunately, the internet is filled with, what's the word I'm looking for? Not helpful information. Sadly, pro-suicide websites exist where they can, people have gotten very creative at all the different ways that they can hurt themselves, and it wouldn't be hard for them to find lethal means if they haven't found one yet. So I would take that extremely seriously.
And another comment, just in case others can't see the chat or if you're joining us by phone, but apparently the AFSP is focused on supporting the passage of legislation that would provide federal funding for bridge barriers, as well as working with state departments of transportation and state and municipal governments to establish regulation and funding for barriers. So that's a great initiative. Hopefully that goes through. Another question here, how do you suggest navigating when peds make statements like, I don't want to kill myself unless XYZ, i.e. I have to go to school, my mom takes my phone,
Yeah,
etc.
conditional suicidality. That's fun. Yeah. Well, I think, so what I try to say, so these are like, they're kind of giving you, this is kind of like, something you can fold into the safety plan. So like, the feelings, the thoughts that you have when, these limits are imposed upon you, that this is something that, causes you pain. This is something that causes you distress, and so instead of killing yourself, can we try these other things first? And if they say no, then your hands are tied until you find something else. If there's like, you're basically saying like, yeah, until they can commit to a safety plan, until they can collaborate with you, if they're threatening to commit suicide, or they should be at least closely supervised, if not, continue to be monitored or hospitalized at that point, depending on the situation. But, oftentimes it's like, it's part of a behavior plan that people or kids might learn. This is like a behavior I can communicate that I want to kill myself unless you're going to give me my phone. If you find other ways to combat that behavior, usually the behavior stops if like addressed with a well done behavior plan. But it can be part of the safety plan too.
Another question here, I've seen more suicide attempts by hanging. Is this something that trended in social media or just spurious?
Yeah, we have seen that. Hangings are, as far as I know, they seem to be increasing. So I'm not sure if it's because of social media. I'm not a fan of the idea of social media personally, so I'm liable to blame it on that because, there is a suicide contagion kind of aspect to it. I did see a patient whose, I think, boyfriend committed suicide by hanging on Facebook Live. So yeah, that's out there. But I'm not sure what the reason is, but I definitely agree that suicide by hanging seems to be increasing in youth.
And we have a comment from someone in the chat that it's supposedly part of a game, so I wonder if it's some kind of challenge or something.
Oh,
I haven't heard of that trend, so.
yeah.
And I just wanted to share this because we really appreciate your talk, Dr. Payne, and the other BHIPP crisis talks that we've had. So we have a participant, I know that's part of a rescue squad, I think has already left now, but has said that they share the information after every class and they implement new practices because of these trainings. So it's wonderful to hear that feedback. We really
Great,
do
thank you.
appreciate this topic. I'm not seeing any more questions as of right now. So I think we can go ahead and wrap up. I'll just have a few housekeeping notes. Again, the CME and CE certificates will be sent within 3 business days of the evaluation. And the link for that we'll put again in the chat. We have another webinar actually next week. It's a BHIPP resilience break on types of mental health evaluations and when to recommend them. And that's on Tuesday. The registration link is in the chat. And as we all know, this suicide prevention is a very important topic, and it has increased during the COVID-19 pandemic. So as part of our webinars, we like to share this information on social media. So if you could tag us, we have all of our social media in here, tag us and share something that you've learned today so we can continue to spread awareness about this. And then of course, you'll be entered to win a free BHIPP water bottle, so it benefits you directly as well. But thank you all for coming today. We appreciate your time. Any closing thoughts, Dr. Payne?
No, I just think it's awesome that we had such strong interest in this talk, and I was very honored to be part of this effort. And I look forward to seeing you at our next talk.
Thank you.
Bye-bye, everyone.